We're going to transition now to talk about hormonally active tumors. These are both some of the most challenging and most rewarding things to treat. Very satisfying to see normalization of growth hormone and cortisol in these patients. Lisa Nachtigall is going to be talking to us. She's going to give us an update on the management of acromegaly, talking about some of the most recent developments in treatment. Thanks.
Thank you so much for that introduction again, and Dr. Zeta for a really terrific presentation. Those videos were just outstanding, and as endocrinologists, we really can't function in a pituitary center without that critical neurosurgical expertise. So to shift gears now, I promised I would talk about acromegaly, and I'm going to give you my whirlwind talk, because this is usually an hour lecture, and we're doing it in 20 minutes. And John said, just the highlights, just what's new, because you're a very sophisticated audience. So that's what we're going to do. So causes of acromegaly, almost always, as you know, with this disease, unlike Cushing's, you are going to see a pituitary tumor, usually a macroadenoma. And it's exceedingly rare to see the absence of a tumor, even rarer to see cases where you have ectopic GH, RH, or GH. When I used to give this talk just about less than a decade ago, I used to tell people when they asked what causes acromegaly that we don't know. And when patients with it asked me if they had to worry about family members, I said no. And that's still true in many cases where we don't understand what's causing it, but the genetics of this syndrome have expanded, and there are many, many mutations that have now been found to be associated with certain familial syndromes that cause acromegaly. I think it's important to be aware of them. So MEN1 is probably the one you all know about, where you get pituitary tumors in combinations with hyperparathyroidism and or pancreatic tumors. Carney complex, you'll see patients that have spotty skin pigmentation, often these exquisite turquoise nevi that look like tattoos in the setting of other endocrinopathies. And in McCune-Albright syndrome, where you can see this disease occurring early, there can be precocious puberty, cafe au lait spots, and ACTH-independent Cushing's, as well as fibrodysplasia. AIP mutations is the mutation where you see just acromegaly in families, and it's a tricky one. So these are giants from the 1800s, and this is mom and dad. And you can see that they have well exceeded their expected height potential. And in fact, they are a family that are considered familial isolated pituitary adenomas. 18%